history of vertebrobasilar aneurysms. I was formerly working in Finland, Helsinki, but now 3 years in China at Henan Provincial People's Hospital. So my experience is mainly based on the Finnish experience from Eastern Finland, Kuopio 17 years, and then 18 years as a chairman in Helsinki. So we have a very good databases from these two centers with more than 18,000 patients with more than 22,000 aneurysms. And also a big number of posterior circulation aneurysms. Personal experience, more than 600 of these, so more than 6,000 aneurysms and around 10% posterior circulation aneurysms. So after beginning to do CT angio, we noted that the number of the vertebrobasilar aneurysms is around 1/6 of all the aneurysms in our material. And vertebral pica aneurysms were 45%, basilar tip, same amount, and then basilar trunk, vertebrobasilar junction, between them, 10%. Here in Zhengzhou in China, there is extremely strong endovascular team with more than 7,000 angios or procedures a year. There are more than 1,200 cerebral aneurysms, and as mentioned, endovascular is extremely strong. Who is coming to microsurgery? These are poor patients, patients without insurance, so 1/4 are operated on by clipping or bypasses. Also a huge number of moya bypasses is done in our center. So I go to the posterior circulation aneurysms. I begin from below. This is a vertebral pica aneurysm, unruptured, clear anatomy. We use CT angio for diagnosis and also for surgery. Of course, we had better pictures than in these videos. 3D pictures. Park bench position. I have always done lateral suboccipital approach, and what I have noted, if the aneurysm is more than 10 centimeters above the skull base, foramen magnum, then you can do very simple thick craniotomy without going laterally. When lower than 1 centimeter, then you have to do what I call enough lateral approach. But here, regular approach, going to distance, CSF released. Many times I'm putting in posterior circulation aneurysms, spinal drain. In this case, not because it was unruptured. I was counting that I get very well CSF out and dissecting sharply. And this is vertebral artery, lower cranial nerves. And then we see already the aneurysms. For the vertebral pica aneurysms, special is that the pica is always coming from the base of the aneurysms. The same counts for basilar superior cerebellar aneurysms and one aneurysms and pericardal artery aneurysms. So these are better done by microsurgery than by endovascular. So this is putting the pilot clip on the base of the aneurysm and then putting a cotton between the clips because they are stuck to each other to have temporary clip out from the vertebral artery. Carefully taking care of the cranial nerves and then coagulating down the aneurysm. Opening the aneurysm. And after opening, again coagulating down the aneurysm. And then doing ICG to see that this is what I call to sleep better. I put one more clip there, and also to support the clip company. So ICG was done and the pica was open, not included in this video. These are the post-operative CT angios, showing the patency of the pica. The next case is very distal pica aneurysm, poor grade patient, severe subarachnoid hemorrhage. So this patient was operated in prone position because of the location site of this distal aneurysm. Poor grade, acute surgery, prone position. And this is midline subaortic approach. I like to operate from the side when I'm doing. And I open many times from the skin under microscope using the mouth switch introduced by Professor Yasakil, which I have found extremely useful in all kind of microsurgery because it shortens the operative time 40–50%. One burhole close to the midline, and then doing a low midline suboccipital craniotomy with craniotome cracking out of the flap, bone flap, and then opening as a midline sinus. It is bleeding. And then, of course, everything is filled with subarachnoid bleed. So the anatomy is obscure, but we will find between tonsils, we will find the pica, cleaning the field with water, putting rather proximally now the temporary clip and going distally, sucking the hematoma and blood out, and then sucking, making a small tonsillar resection to come to the aneurysm. Now we come to the caudal loop of the pica and change the position of the temporary clip and come to the aneurysm surrounded by blood, and it is the sacral aneurysm, even located very distally, so the clip is going on the base of the aneurysm, removing the temporary clip, and checking of the distal pica. Many times when done by endoscopy, they are occluding the pica, but then you get infarction. So this is not good. They should be done by microsurgery, these aneurysms, because you can preserve the distal pica. And this is ICG, shows the patency of the pica, and then hemostasis and closing in layers, and these are the postoperative controls. Patient made good recovery in spite of the poor grade initially. Then we go upwards. This is again an acute case, grade 3. This is a very large or giant vertebrobasilar junction aneurysm. Patient operated by pre-sigmoid approach. I go for the proximal control. I put a temporary clip on the contralateral vertebral artery, then ipsilateral vertebral artery, and then above the aneurysm I put a temporary clip on the basilar artery. And now, after with these 3 temporary clips, I'm able to dissect the aneurysm base. There's a lot of subarachnoid blood, broad base coming from the fenestration of the vertebrobasilar junction. The first clip is a ring clip compressing the base of the aneurysm. I think it was a straight clip, straight, strong clip. Yeah. And the problem here is now, you will soon see when removing the temporary clips, there's one perforator inside the clip. It is obstructed. This perforator is obstructed. What to do now? Don't remove the first clip, because you can use it even you have put it in the place with your best skills. So leave it in place and use it. And now another clip is going distal to this clip. I call it traveling with the clips. So slowly advancing this clip deeper. The aneurysm is giant and very strong. Then slowly closing the clip now. Temporary clips have been removed because we have this clip closing the main part or closing the base of the aneurysm. Now, so one clip, and then I have to put one more clip distal to the second one. And with the help of these additional clips, I can remove the first clip that is obstructing the perforator. One more clip is going there, and now I'm able to remove the first clip. You have to be very careful with the clips when you have many of them, so that you don't make any complications when removing the clip. And now the perforator is free, and the ICG showed that the perforator is filling. It looks that there is some remnant, but as you see in DSA, it is exact clipping of the aneurysm patient made recovery. So let me go upwards. Next, we saw beautifully basilar trunk aneurysm by Alex Beast, so I will not show that. This is basilar superior cerebral artery aneurysm. Here, as I mentioned, it's typical that the superior cerebral artery is coming from the base of the aneurysm, like you see here, 3D. So I used to go from the side where the fundus is, and I go subtemporal. I'm doing subtemporal approach. For this one, you have to position. I'm positioning always the patient myself, and then you have to have spinal drainage. Otherwise, you cannot do subtemporal approach. You have to have slack brain with good anesthesia. You have black brain, but you need additional help from the spinal drain, draining 50 to 100 milliliters, and then going down. Now this is trochlear nerve, and then you cut the tentorium behind trochlear nerve to come lower. And fix the tentorium to the middle fossa with small microclips, pushing them through. And then now we identify superior cerebral artery. This is basilar artery. There we have put the temporary clip. So right superior cerebral artery. This is the aneurysm. Temporary clip is going to the basilar artery. Third nerve is always between superior cerebral artery and one. This is the only thing in the world that remains so. No variations in that. And when clipping those basilar superior cerebral artery, and also you have to use curved clip, preserve the superior cerebral artery. Here I have 2 clips in place, and then have coagulated down. And also replace the clip several times to preserve superior cerebral artery, and there are also perforators close. They might come also from superior cerebral artery, so you have to take care of them. And now see once more the anatomy, basilar artery, aneurysm coagulated down, change the clips, and then ICG is done, and the perforators are filling. Superior cerebral artery is filling. This is very important because it is coming from the base of the aneurysm, and then this is the final situation here, and removing the clips from the holding tentorium, the final stage. Postoperative images here. So aneurysm is gone. So ruptured aneurysm, patient made good recovery. And superior cerebral artery filling. This is very important. So we go upwards. All these videos can be seen in free internet in 1001 video collection. This is ruptured basilar tip aneurysm. I used to operate them by subtemporal approach, except those which are high or have multiple aneurysms in anterior circulation. It is once again the subtemporal approach. And you have to have spinal drain, as mentioned, and then very gradually retract the temporal lobe carefully, and then you come to basal cistern, filled with blood here, filled with blood, acute surgery. So opening the tentorium behind trochlear nerve. Why are you opening the tentorium? To come lower, to come to the basilar artery, to put the temperature. So I wouldn't really end with temperature because the premature rupture is extremely difficult to deal in the small gap. Important drug now. And rinsing, cleaning the field from subarachnoid fluid. And you see here, subarachnoid space full of blood, and oculomotor nerve is the route to the basilar tip, always lying between superior cerebral artery and P1. So you If you don't know where you are, just follow the third name, and then you will come to the basilar tip, and you will see now already the aneurysm here. It was directed upward, forward. So this is basilar artery. Inside the blood, I put temporary clip on the very strong P-cam, and then I put also temporary clip on the basilar artery between the perforators. And now I can dissect the aneurysm base. And here you note that before clipping there is still temporary clip. I was thinking I take it away because you might have difficulties to take the temporary clip out. Because now the handles of the clips are extremely close to each other. So now dissecting the aneurysm, removing the P-cam. Strong P-cam is giving blood to the basilar tip, and then removing the temporary clip from basilar artery. And then dissecting the aneurysm. Here we see the posterior cerebral artery. And checking the patency with Doppler. And then opening the aneurysm. We have done a lot of aneurysm wall studies since beginning 20 years ago. So we have big collection of specimen. I think close to 1,000 specimen. And then cut the aneurysm, cleaning the field, and put papaverine. And take the supporting retractor away. And push fibrin glue in the place where the microclips were holding the tentorium. These are postoperative controls. The patient had ventriculostomy before this operation. Good. And we have next case. We ruptured P1, P2 aneurysm, also extremely heavy subarachnoid hemorrhage, poor grade of the patient, but surgery. This is the aneurysm. Here are more pictures. This video collected from aneurysm. This aneurysm is at the level of the posterior clinoid, above the posterior clinoid. It could be done also by subtemporal approach. I selected here the rather a supraorbital approach because there's extremely heavy subarachnoid hemorrhage, and I was thinking that it might be difficult to subtemporally this aneurysm. So lateral supraorbital approach was elected. This is the patient. And incision, short incision, then opening the dura. Please note how slack is the brain. Extremely good anesthesia in Helsinki neurosurgery. So the people visiting Helsinki were always first note, the brain is so slack. This is extremely skillful anesthesia, and then going down. The brain is tight, then you go to lamina terminalis and basal systems, open them. For some reason, I first clip on the carotid artery, but then temporary clip is going on the P1, and then we can dissect the aneurysm, and you see it is bleeding. I take the bleeding inside the sucker, and then the clip is going up base of the aneurysm. And then calculating down the aneurysm and ICG done. P1 open. And this is the postoperative CT angio. Postoperative CT. And your perfect clipping of the aneurysm. The patient, in spite of severe bleeding and poor grade, made good recovery. And this is the last one. The giant basilar aneurysm. Old lady with this giant aneurysm. That was done a subtemporal approach, again, right side, dissecting carefully here. The anatomy is more clear. This was the trochlear nerve and the cutting of the tentorium, fixing tentorium to the middle fossa with clips, and then dissecting the base of the aneurysm, putting temporary clips on the basilar artery, and then opening the aneurysm. That is, of course, this is no return. This is no return. You have to now to clip the aneurysm. So opening the aneurysm, sucking the blood, and then first clip, ring clip is always good on the giant aneurysm because it is not slipping away. First clip, remove. Cover limit the clips. You have to leave some base in these giant aneurysms, otherwise you will occlude. Artery is coming from the bifurcation. So now still bleeding. There's retrograde filling. So several strong clips. I removed the most proximal clip and add one more strong clip distally, long clip. So the clip length must be 1.5 times the base of the aneurysm. This is how long the clip should be, not longer, but not also shorter. And this is the ICG showing the posterior cerebral artery filling, checking with microdoppler. And this is postoperative images, and this is postoperative DSA. Perfect clipping with microsurgery. So the question is, can I do it again? I can do it again. Can I repeat it safely? I think as safely as earlier. But the question is, am I allowed to do it again? This is not the case. Here, the endovascular is extremely strong, and if the patient is not treated by endovascular, the patient is usually sent home. Can someone learn this microsurgery? Certain can learn. With the present time, in the present time, there's huge pressure from surroundings. You need extremely supportive team to do posterior circulation aneurysm surgery, which is actually not done anymore in China. You should have no angry eyes in your operation room. You should not have gossiping around you. Everybody in the operation room should be working for the most important person in the operation room. This is the patient. So there's huge pressure for open microsurgery from surroundings, media, colleagues, lawyers, and the population. Here in China, population is afraid of opening of the head, and this is increased by the endovascular information. And also the way they take all the hair before craniotomy away. This is also one of the things going in favor of endovascular surgery, total saving of the beautiful Chinese female hair. So what you need, good teamwork. No one can do surgery alone. This is Helsinki, one of the best scrub nurses, Anna-Lena here, and this is here in Henan, good teamwork, good scrub nurse, good anesthesia, scrub nurse Ping here. We are doing well here in operation. These are my teachers in anal surgery, late Professor Drake, and of course, Professor Yasakil, father of all microneurosurgery in Chicago, learning still anatomy after thousands of operations. The anatomy is the most important thing in doing microneurosurgery. We wrote with Dr. Pieles 25 years ago this sentence: we continue to enjoy placing the perfect clip around the base of those deadly sacs. Professor Pieles was one of the first fellows by Professor Yasakil already in the end of 1960s. So perfect clip around the base of these deadly sacs remains the best treatment. Unfortunately, the skills are going down, or at least becoming more seldom. And thank you very much for your attention.
Thank you very much, Professor Hernesniemi, for outstanding talk as always. I think we have time for a couple of questions. I don't know whether there is any question from the audience or the other panelists. If not, I have one question. I think we all have seen the presentation of Professor Ali Christ regarding the treatment of basilar aneurysm, doing the complex procedure of the cavernous sinus approach. In your huge practice, how often do you think this procedure is necessary to clip vertebral basilar artery aneurysm?
I have used more subtemporal approach. There are some tricks to use subtemporal approach. You have to have extremely good anesthesia, then you have to use always the spinal drain. Otherwise, you should not go there because you destroy the temporal lobe. You have to have tender hands to retract the temporal lobe. Then you can do it by subtemporal. I have done the Transilvian approach through lateral supraorbital approach. In those cases which are higher, about the posterior clinoid, more than 6-7 millimeters higher, then you are retracting too much temporal lobe, these cases. And if the patient has additional aneurysm in the anterior circulation, you want to take time. So main part of my vascular aneurysms have been done by subtemporal approach, which was introduced by Professor Charlie Drake in 1959. He made his first case by subtemporal approach. And Oliver Gruner made 1954 first approach basilar aneurysms.
Thank you very much. Is there any question, Professor Canan, Professor Benes, or any other colleague? I have a second question because we have also seen one of the presentation from Professor Kato showing some microsurgery assisted by endoscopy procedure Do you miss really endoscopy in your cases, or you think microsurgery alone can accomplish the great majority of the cases?
Of course, nowadays the endoscopy is good. When I tried first time in 90s, so the endoscopes were very thick and clumsy at times. So I didn't continue with endoscopes. But I think nowadays you have such a fine endoscopes, and this will increase the accuracy of the clipping. Certainly, I have not used, but I have made many mistakes. So I didn't take navigation in the beginning because I thought I can the anatomy enough. I'm enough good in anatomy. This was a mistake. Then I had to repeat that. And then endoscopy. I made a lot of endoscopy in 90s, but I was not so happy with the system. And
Miguel, Miguel, I have one question.
Sure.
Miguel?
Sure.
Actually, I want to get the opinion of Professor Vinko because I will take the opportunity he's with us for the whole session today. And about basal artery aneurysm, have you used the complex skull-based approaches in most of the cases, or you have modified it according to the position of that aneurysm? Because I am rephrasing the question of Professor Miguel to Professor Juha.
I'm not as good in skull-based surgery like Vinko, Ali, or several others here. So I was happy with the subtemporal approach because you don't have to remove any skull-based there. This is a very fast approach for.
Professor Juha, there is nothing wrong with this approach you are practicing. You have done hundreds of thousands of cases with good results. But I'm just wondering for the new generation, we have, of course, many young people they are attending. Do they have to do always a complex skull-based approach, like a fronto-orbitozygomatic, or they can do the pure terional approach, flattening the orbit, decompress the optic canal, take the anterior clinoid, it will suffice adequate for the exposure of basilar tip that are reasonably approached anteriorly as well? Vinko?
I have done skull-based surgery in carotid ophthalmic aneurysms, and those aneurysms getting in, having their base inside the cavernous sinus. Of course, you have to do in those cases to be able to clip these aneurysms totally, and of course, to learn the route of Vinko and Ali Christ is extremely useful because you can use it also in tumors. So my practice has been different, and of course you cannot repeat your whole life. Sometimes the time is ending.
Vinko can comment. Dr. Vinko, and I'm seeing Dr. Ali as well. He is on the screen now. So again, I rephrase the question. I don't know whether you heard the questions properly. Do you use in most of the cases of a basilar tip aneurysm where you go anteriorly, not the subtemporal? Subtemporal is very clear for me with Professor Juha. But for an anterior approach, is sometimes a pure terional with taking the clinoid and decompressing of the optic nerve suffice adequate for that approach, or not? You still have to take the orbital rim and part of the zygoma.
You know, I was really enjoying to listening to all these questions and to all these lectures. And what can I say is just the principal things are the corridors to the aneurysms. And then when you explore and when you have enough space, and then you can do the job. I saw in several cases putting the temporary clips on the basilar artery. And I mentioned in my previous lectures ago that I learned this from Peter Bentivoglio from Australia. He did the experiments on animals, on baboons, for how long the animal could tolerate occluding of the basilar artery. He came with the answer that putting the clip on basilar artery for 3 minutes, you can then dissect the aneurysm and the daughter arteries, and then you release the clip for 5 minutes to get oxygenation, vascularization, perfusion to the surrounding tissue. And I was using this ever since I heard this from him, and it was always beneficial for our surgery. So I think we do not have 100% sure data for how long can we put the clip on the proximal artery, where from the aneurysm is coming. So we are still in a little bit foggy in the carotid system as well as on the basilar system. But this was our guide for the basilar system. According to the removal of the clinoids and so, this is just to gain the space, to gain, when there was a question, what do you do, Vladimir asked, what do you do when you have a high aneurysm, a basilar tip? Nothing, you just go a little bit more down. You resect more bone, and then you go more from below, and you can reach it. So, trajectory, canal, safe, exploration, dissection, that's it. Thank you.
Matt, can I say something?
Yeah, sure. Go ahead.
Yeah.
May I add? Okay.
Go ahead, Juha.
I wanted to just say about the temporary clipping of basilar artery. I studied the cases of Drake and PLS, so more than 1,000 basilar tip aneurysms. So it was always safe with single occlusion, less than 5 minutes, and with multiple occlusion, less than 15 minutes. This came out, and we have published it with Hussein in Chinese journal. These results, but they are also in the Drake PLS book.
I learned this from
5 and 15.
I learned this from Peter Bentivoglio. It was in
Maybe the
80s, early 80s.
The communicating arteries might be very different in the basilar tip. You have strong peak arms or very minimal, so this influences the occlusion time. But 5 minutes single occlusion, always safe, and then repeat it less than 15 minutes.
Thank you. Ali, please go ahead.
Yeah, I want to say, you know, as Dr. Arrais said, that he said, what do you think about doing this complex approach? To me, it's not complex. Complexity is lack of knowledge. Complexity is lack of experience. Simplicity is when you, to me, I live in the cavernous region and I go in and out every day. So we shouldn't anymore, a difficult case is a case that we're not prepared. A difficult case is a case that we didn't expose enough. So, and I don't, if you notice, I called it variants of the transcavernous approach. I don't remove everything in every case. In one case, I showed the last cases, I went full transcavernous. I got a wide exposure, I achieved safety. In other cases, like a high riding one, I don't remove the posterior clinoid. I will go temporal so that I can get more space and look up. So there are variations you use. So it's like going to war. You don't go to war with one bullet and assume the enemy is one color. Because if you do a pterional approach, you will encounter one patient case where the carotid is kissing the third nerve, is kissing the optic nerve, and you don't have space. You can do epterional. I have several cases where the anatomy was favorable. I can show you a beautiful video, and I cannot claim that the epterional approach was great for this case. If you're gonna deal with basilar aneurysm, the price is so high, you have to go in with all the weapons in your hand, and you use it as needed. In this way, you guarantee success. Otherwise, you will not. Because the alternatives, I have shown cases. If you come to my clinic, you will see catastrophes of coiled aneurysms that ended up as malignant cases, like I have shown, that you cannot do anything and the aneurysm is growing. Now, we have to, go into this phase now. Cavernous sinus surgery should stop being looked at like this forbidden city. It is not. Vinko opened the door. We should do, like he said, better. And in the future, it's going to be better. I can tell you, my cases take 2 hours. Full cavernous approach exposure, 2.5 hours. Why? Because the road and the roadmap is already established. And the problem with bleeding is no more there with the fibrin glue. It's a technique that we published about the cavernous. I saw Juha use it. We took this approach. And if all what I can tell you is, please come to it and see it. Next day, you will be convinced. Juha had seen it. Vinko had done it and seen it. So for the future, please stop saying this is complex. Complexity is our ignorance about something. Then we feel like it is difficult, because the complex becomes simple when we master it. If we go in there ill-prepared, we're going to lose. But we have a lot to gain in the future from learning this route. You can get to the brainstem, you can get to the hypothalamic region, you can get down to the pons. There is so much pathology you can benefit from this approach doing in that region in a beautiful way. And the future, I can tell you now, forget what you say, the younger people are convinced now. When I come, I have so many fellows and young people that send me beautiful videos that they're doing in their hometowns of surgeries, because they are going and spending time in the lab. So again, it's our understanding of complexity comes from our lack of knowledge. If you know something, you master it, it's gonna become simple.
Thanks, Ali, but I'd like to recharge. There is a common trend now to come back to the simplest approach. And we are not, perhaps the wording used, complex, is, sorry to say, is not the right word, but sometimes it's a time-consuming, sometimes a mindset done for every case that he wants to take the fronto-orbitozygomal, he wants to cut the zygoma arc, unnecessarily for all cases. I'm just referring the cases that Professor Yazargil, in his experience, that time we did not do all these advanced skull-based. I'm a skull-based surgeon. I have done all these. But I see sometimes a trend that it will be done by a mindset. Sometimes you are doing the flatten the orbit, you take the clinoid, anterior clinoid, and we have to remember, Professor Yazil mentioned something very important, especially in aneurysm surgery. You said it yourself. It's not a tumor surgery that you need more space than the aneurysm. We need the space for the aneurysm surgery, but draining CSF from opening multiple cisterns, it gives you plenty of space that can compensate to some of this bony removal and minimize the retraction. So we should not neglect this part completely. And I think the experience of Professor Yazargil was without all these complex, as I said, not complex, but advanced skull-based approaches.
I agree. Why don't you ask him later, what does he think? He's the one who pushed me to do this, by the way. So ask him about what I'm doing for basilar, what he thinks.
No, it's not matter of asking. I'm to
serious.
give
I'm serious.
wording for the people, because some people, they will say, why you are taking much more bone than needed.
We're not.
We like the word tailored, sorry to interrupt you. We like the word tailored skull-based approach. You drill the anterior clinoid if you need to drill it. You take for sure, you take the lateral and medial sphenoid wing. Orbitozygomatic, does that need it for every case?
Well,
Flattening
I
the orbit
don't-
does not replace. Go ahead.
if you look carefully, Ahmad, I didn't take the orbital rim in any case, by the way. This was only a pterional approach with a more temporal exposure. That's all. That's all what it is.
That's what
And
I want to confirm.
Yeah, and
That's
I don't
what I want to hear.
Yes,
Yeah.
that's all what it is. The only difference is I do more middle fossa, widening the corridor so you can get more
Yeah.
proximal control. That's what I do. I
This
haven't
is
taken
perfectly
in
well.
those,
No,
in those
this is
cases,
perfectly
I haven't taken the zygoma maybe twice in very high riding ones, and the orbital rim I haven't taken in a single one from these 188 cases that we have done. Now, if you have to do it, it's okay. If we have to add the approach, like you said, you use the word tailor, we tailor it. But this is tailored for safety. That's important to know. What I
Sure,
am doing is we are tailoring for higher safety and more guaranteed complete occlusion of the aneurysm. So
we are on the same wavelength as you said. You mentioned that you have not taken the rim in every case. You took it only twice. You did not get the zygoma in every case. This is the original fronto-orbitozygomatic approach. That's what I said, a set mind about, I am doing fronto-orbitozygomatic for a procedure. They start cutting all these bones before they start the procedure. And I think they should be judicious, as you say, encouraged to move forward, but judicious with the tailoring what they need to do, as you said. Thank you.
Gentlemen, I believe you are talking the same thing. Actually, the best example of this is what Juha has started. Juha has coined the term enough lateral. We were talking about far lateral, extreme lateral, whatever, transcondylar, and Juha started using the term enough lateral. Tailored approach for the task you are going to do. And this is exactly the same. Ali, do I understand it properly?
yes, I agree fully. The only thing I would add is we have to learn these extra steps. Like I said, you don't go to war with one bullet because you don't know your enemy sometimes. You have to be with the knife, with the bullet, with a machine gun, with everything. And but you're able to use it. The problem is if you go there and you know only one approach and you cannot add to it, and then you encounter very non-favorable anatomy, you are stuck. You cannot be stuck. If you go in, like I said, you go in with a winning mentality. You have to have all the options. Otherwise, you're going to lose some, or you're going to call it a difficult case. It wasn't a difficult case. You were not prepared. That's why it's a difficult case.
A very good message, actually. They should be taught and learned and used whenever it's needed.
Okay. I think it's
sorry, Miguel, we took many times for this.
As I said, the file, let me say something. That first of all, that I very much appreciate, Dr. Chris, your wonderful approaches. And I think that we have young colleagues in the audience. And I think the message should be that instead of considering easy or difficult the approach, I think that the way of doing things is going to the lab. And I think this is something that you have been continuously transmitting to the audience in your presentation, instead of saying this is easy or this is difficult. It's difficult if you don't know how to do that. But being said that, and being said, I like very much skull-base surgery. I've been doing that over more than almost 30 years. And I think that one of the key issues is knowing all the possibilities skull-base for every case that could be tumor or vascular or wherever. But at the same time, we have to be aware that there are several different complexities in approaches. We cannot transmit to the young colleagues that cavernous sinus surgery is a very easy approach. Maybe for you, maybe for somebody else, but after having years and years of practice at the lab and clinical practice. This is my consideration. And talking about that, there are several differences. It's not Therianal approach, it's not the same Therianal approach, or COC, or formal cavernous sinus approach. I think we have to thank you anyway for your contribution.
Just one of my slides, if you remember, it says, know your limits, but at the same time have no limits.
No limits, yeah.
This is one. This is maybe just before the last one. Thank you.